Hepatocellular carcinoma, continued. LI-RADS is an imaging reporting and classification system for HCC on CT and MRI, which is an indication of the relative risk of HCC ranging from LR1 favoring benignity to LR5 favoring malignancy. This is used only in people with risk factors for HCC, chronic hepatitis infections, cirrhosis, but not cirrhosis due to cardiac or vascular etiologies. The 2018 version describes major and ancillary criteria. The major imaging criteria lead to the assignment of the LI-RADS score, while the ancillary findings may be used as tiebreakers. Major criteria for HCC. Arterial enhancement. Non-peripheral washout on portal venous in delayed phases. Enhancing capsule, pseudocapsule seen in portal venous or delayed phases. Threshold growth with diameter increase of greater than 50% in less than 6 months. Ancillary findings favoring HCC include non-enhancing capsule, nodule in nodule architecture, mosaic architecture, fat in mass, blood products in mass. Treatment options for HCC include partial hepatectomy, orthotopic liver transplantation, radiation therapy, percutaneous ablation, and transcatheter embolization. Fibrolamellar HCC. Fibrolamellar HCC. Axial CT top left image shows a heterogeneous lesion corresponding to heterogeneous signal on T2 weighted MRI top right. DWI bottom left and post-contrast bottom right images show hypercellular enhancing components within the mass arrows. Fibrolamellar carcinoma is a rare subtype of HCC that occurs in young patients without cirrhosis. The tumor tends to be large when diagnosed but has a better prognosis than typical HCC. Unlike in conventional HCC, AFP is not elevated. On imaging, fibrolamellar HCC is a large, heterogeneous liver mass. A fibrotic central scar is classic, which is hypointense on T1 and T2 weighted MRI images. In contrast, focal nodular hyperplasia features a T2 hyperintense scar that enhances late. Capsular retraction may be seen in 10%. Unlike HCC, the fibrolamellar subtype does not have a capsule, although there may be a pseudocapsule of peripherally compressed normal hepatic tissue. Mass-forming cholangiocarcinoma. One of 3 recognized subtypes of intrahepatic cholangiocarcinomas and usually presents as large and relatively well-defined hepatic mass with lobulated margins and demonstrates delayed, progressive enhancement. They are often associated with peripheral biliary dilatation and, although biliary in origin, must be considered in the differential for a hepatic mass. Hepatic metastasis. Metastatic disease to the liver is far more common than primary HCC. Although metastases are supplied by branches of the hepatic artery induced by tumoral angiogenesis, most metastases are hypovascular and best appreciated on portal venous phase, in contrast to HCC, which is hypervascular and best visualized on late arterial phase. On MRI, metastatic lesions tend to be hypointense on T1 weighted images and hyperintense on T2 weighted images. Blood products and melanin, seen in melanoma metastasis, are T1 hyperintense. Metastasis can have a variable ultrasound appearance, although the classic finding is a hypoechoic rim producing a target sign. If an incidental liver mass is seen on ultrasound, further characterization by MRI is recommended. Enumerable liver metastasis on ultrasound, initially difficult to see due to technique. Initial scanning with a low-frequency vector probe, left image demonstrates a coarsened hepatic ecotexture without definite mass. This appearance may mimic cirrhosis. When a higher frequency curved probe is used, right image, enumerable target lesions, arrows become apparent, consistent with enumerable hepatic metastasis. Case courtesy Julie Rittner, M. Hypovascular hepatic metastasis include breast, pancreas, lung, lymphoma. Hypervascular hepatic metastasis include mnemonic equals MRCT, melanoma, renal cell carcinoma, carcinoid choriocarcinoma, thyroid. Calcified hepatic metastasis include mucinous cancers including colon, gastric, ovarian, osteosarcoma, treated lymphoma. Hepatic metastasis continued. Cystic hepatic metastasis include ovarian cystadenocarcinoma, gastrointestinal sarcoma. Pseudocirrhosis describes the macronodular liver contour resulting from multiple Schraus hepatic metastasis with capsular retraction, mimicking cirrhosis. Although termed pseudo, these patients may have similar physiologic consequences of cirrhosis including portal hypertension. Treated breast cancer is the most common cause of this appearance. Pseudocirrhosis due to multiple treated breast cancer metastasis. Contrast-enhanced CT shows numerous hypotenuating hepatic lesions with a markedly nodular external hepatic contour arrows that resembles cirrhosis. Liver function in this patient remained normal. Hepatic lymphoma. PET-CT demonstrates a single defined low-density hepatic lesion arrow, left image, and more diffuse low-density changes of the liver parenchyma with remarkable FDG avidity, right image, in this patient with biopsy-proven hepatic lymphoma. Primary hepatic lymphoma is very rare and may present as a single mass or multiple masses. They tend to be infiltrative and preserve hepatic vasculature. Lymphomatous involvement of the liver tends to be secondary to systemic disease, with associated splenomegaly and lymphadenopathy. On ultrasound, lymphoma tends to be hypoechoic and may have the target sign typical of metastasis. On CT and MRI, lymphoma is hypoenhancing and tends to show restricted diffusion on MRI. Post-transplant lymphoproliferative disorder, PTLD. PTLD appears as a mass with a variable and nonspecific appearance. Therefore, it is important to mention PTLD if a liver mass is seen in a transplant patient. This is discussed further later in the chapter. Epithelioid Hemangioendothelioma. Pre-contrast T1 weighted MRI. Post-contrast T1 weighted MRI. T2 weighted MRI. Multisequence MRI shows multiple T1 hypointense, T2 hyperintense hepatic lesions with peripheral target pattern enhancement arrow, predominant peripheral distribution, and associated capsular retraction not shown. Epithelioid hemangioendothelioma is a rare vascular malignancy that characteristically causes multiple spherical subcapsular masses that can become confluent. The individual masses may have a halo or target appearance. Epithelioid hemangioendothelioma is one cause of capsular retraction. As summarized at the end of this section, the differential of capsular retraction includes mass-forming cholangiocarcinoma, fibrolamellar HCC, seen in 10% of cases of fibrolamellar HCC, epithelioid hemangioendothelioma, pseudocirrhosis, macronodular liver contour with capsular retraction due to treated metastasis, confluent hepatic fibrosis, wedge-shaped fibrosis that may be seen in cirrhosis, benign liver masses, hemangioma, early arterial post-contrast T1 weighted MRI, portal venous post-contrast T1 weighted MRI, delayed post-contrast T1 weighted MRI, T2 weighted MRI, hemangioma, dynamic contrast enhanced T1 weighted MRI, early arterial top left image to delayed bottom left image, shows a segment 8 lesion, yellow arrows, demonstrating peripheral discontinuous nodular enhancement. There is progressively increasing centripetal enhancement towards the center of the lesion on delayed images. The signal intensity of the peripheral enhancement is similar to that of the aorta. The hemangioma is hyperintense on the T2 weighted image, bottom right image. Hepatic cavernous hemangioma is the most common benign hepatic neoplasm. It is composed of disorganized endothelial cell-lined pockets of blood vessels, supplied by a peripheral branch of the hepatic artery. Hemangioma is more common in females and uncommon in cirrhosis. When a known hemangioma is sequentially followed in a patient with early cirrhosis, the hemangioma involutes as the liver becomes more cirrhotic. Hemangioma may range in size from less than 1 cm to greater than 10 cm. Giant hemangiomas tend to have a non-enhancing central area representing cystic degeneration. On CT and MRI, a virtually pathognomonic imaging feature is peripheral discontinuous progressive nodular enhancement. The degree of enhancement should match the blood pool on all images and demonstrate gradual centripetal fill-in on later phases. The non-contrast CT appearance is not helpful, as a hemangioma appears as a nonspecific hypotenuating liver mass. On MRI, hemangiomas are typically T2 hyperintense and become even more hyperintense on T2 fat-saturated images compared to conventional T2 weighted images. Hemangioma continued. The classic ultrasound appearance is a circumscribed, homogeneously echogenic mass with no flow on color Doppler. Posterior acoustic enhancement may be present. If a solitary, classic appearing hemangioma is seen on ultrasound and the patient has an otherwise normal appearing liver, normal LFTs, no known malignancy or risk factors for HCC, and is asymptomatic, then no further workup is required. A hypoechoic halo target sign should never be seen. This finding suggests malignancy. Ultrasound appearance of hemangioma can be confusing in a patient with underlying fatty liver and may appear relatively hypoechoic compared to the background of echogenic fatty liver. Any heterogeneity or atypical ultrasound findings should prompt consideration of an alternative diagnosis such as hyperechoic HCC or metastatic disease, even in the absence of a halo. In a patient with cirrhosis or any known primary malignancy, further work of MRI or CT is usually warranted. Cavernous hemangioma. Transverse ultrasound through the right lobe of the liver demonstrates a circumscribed, slightly heterogeneous echogenic mass, calipers, with mild posterior acoustic enhancement. Portal venous phase axial contrast enhanced. CT demonstrates a hypotenuating lesion with peripheral discontinuous nodular enhancement. Arrows typical of a hemangioma. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Focal nodular hyperplasia, FNH. Focal nodular hyperplasia, FNH, is a hamartoma consisting of disorganized liver tissue with no malignant potential. It is more common in women and is not associated with oral contraceptives. FNH is called a stealth lesion because it resembles background liver parenchyma on all modalities, except arterial phase imaging due to vascular supply. Approximately 15% of FNH have a characteristic central scar consisting of biliary ductules and venules which does not contain fibrotic tissue and therefore is not a true scar. FNH does not have a capsule. MRI with Eovist contrast is the most useful imaging modality to diagnose FNH. FNH typically is isointense to liver on all MRI sequences, except it is arterially hyperenhancing and will show retained Eovist enhancement ISOR hyperintense relative to liver in the hepatobiliary phase 20 minutes after contrast administration, due to the presence of hepatocytes and biliary ductules. The central scar will show delayed enhancement with extracellular contrast agents, such as Gatavist, but will not enhance with Eovist. Focal nodular hyperplasia, FNH, continued. T1 weighted fat saturated MRI. T2 weighted MRI. Late arterial post-contrast T1 weighted fat sat MRI. Portal venous post-contrast T1 weighted fat sat MRI. Delayed post-contrast T1 weighted fat sat MRI. Focal nodular hyperplasia. T1 weighted MRI shows a barely perceptible mass in the right liver, yellow arrows, with a central low-intensity scar, red arrow. The mass is T2 isointense with the subtle suggestion of T2 hyperintense central scar, red arrow. Arterial phase of enhancement shows avid enhancement with non-enhancement of the scar. The mass washes out immediately on portal venous phase, with no change in intensity of the scar. Delayed T1 weighted image shows late enhancement of the central scar, red arrow. Case courtesy of Cheryl Sato, MD, Brigham and Women's Hospital. FNH can be difficult to see on non-contrast or portal venous phase CT as it typically matches the parenchymal attenuation. On a multiphase contrast-enhanced CT, there will be bright and homogeneous arterial enhancement with the exception of the central scar, and the portal venous phase will often show only the unenhanced scar, which enhances late, approximately 5 minutes. Ultrasound findings are nonspecific. The central scar is rarely seen on ultrasound, and even when it is, this finding can be seen in other lesions, including HCC, giant hemangioma, or adenoma. Doppler findings of FNH include a spoke wheel configuration of arterial vessels. Kupffer cells and bile ductules are both present, so nuclear medicine studies can be utilized to confirm the diagnosis. Kupffer cells may be confirmed by a sulfur colloid study, 1/3 of the time, and bile duct cells can be visualized on a HETA scan. Hepatic adenoma. Coronal portal venous phase contrast enhanced CT demonstrates a heterogeneously enhancing hypotenuating mass, arrows, in the liver, which is a nonspecific appearance. In left image and out of phase right image, MRI shows a mass in the right lobe of the liver, arrows, that demonstrates signal loss on out of phase images, consistent with a lesion containing intracellular lipid. Case courtesy Cheryl Sato, MD, Brigham and Women's Hospital. Hepatic adenoma is a benign hepatic neoplasm containing hepatocytes, scattered Kupffer cells, and no bile ducts. The absence of bile ducts makes a nuclear medicine HETA scan a useful test to distinguish between focal nodular hyperplasia, which contains bile ducts and would be positive on HETA, versus a hepatic adenoma, which does not contain bile ducts and will show a paucity of uptake on HETA. Adenoma are much more common in females, especially with prolonged oral contraceptive use. When seen in males, adenoma may be associated with anabolic steroid use. Other associations include collagen vascular disease and type 1 glycogen storage disease, von Gierke's disease. There are 4 histologic subtypes with varied imaging findings. Inflammatory. Most common, has the highest bleeding risk. HNF-alpha-1 mutated. Second most common, characterized by multiple adenoma, associated with FAP and von Gierke's. Beta-catenin mutated. Least common, seen in men on anabolic steroids, has the highest risk of malignant transformation. Unclassified. Hepatic adenoma continued. Adenoma have a relatively high risk of hemorrhage, which is often the presenting symptom. For this reason, incidentally discovered adenoma greater than 5 cm are usually resected. Adenoma are supplied by the hepatic artery and thus tend to be hypervascular on arterial phase. Some subtypes inflammatory may demonstrate intralesional fat, which on MRI will demonstrate T1 hyperintensity and signal loss on out-of-phase images. Adenoma may be difficult to differentiate from other hypervascular liver lesions in the absence of fat or hemorrhage. As stated above, each subtype has slightly different imaging features, making confident imaging diagnosis somewhat difficult and often requiring tissue sampling for confirmation. Adenoma are typically circumscribed masses with arterial hyperenhancement, becoming eyes or hypotoliver on portal venous in delayed phase imaging. They may appear heterogeneous due to fat or hemorrhagic content. A fibrous pseudocapsule may be present, which tends to enhance late. There are no specific ultrasound features to distinguish an adenoma from other hepatic masses. An adenoma may be hyperechoic, isoechoic, or hypoechoic relative to normal liver. Nuclear medicine is not usually helpful to differentiate adenoma from other liver masses. Adenoma are usually photopenic on Tc-99 m sulfur colloid scintigraphy, in contrast to FNH, but not always. There is usually lack of uptake on a HETA scan due to the absence of biliary ductules. Other fat-containing hepatic lesions. In addition to adenoma, other fat-containing lesions in the liver include lipoma, very rare angiomyolipoma, and pseudolipoma of the Glisson's capsule. Biliary cystadenoma, cystadenocarcinoma. Biliary cystadenoma is a benign cystic mass lined with biliary-type epithelium. Although benign, most are surgically resected since malignant transformation to cystadenocarcinoma may occur. These typically appear as a multiseptated cystic mass on all imaging modalities. Cystadenoma and cystadenocarcinoma are not easily differentiated on imaging. Mural nodules should be regarded with suspicion for malignant transformation to cystadenocarcinoma. This is further discussed under biliary neoplasia later in the chapter. Enhancement patterns of common hepatic masses. Arterial phase, portal venous phase, delayed phase. HCC up pointing arrow down pointing arrow down pointing arrow, FNH up pointing arrow, iso hepatic adenoma up pointing arrow down pointing arrow down pointing arrow. Hypervascular metastasis up pointing arrow or iso down pointing arrow or iso down pointing arrow or iso. Non-hypervascular metastasis down pointing arrow down pointing arrow down pointing arrow. Hepatic infection. Viral hepatitis. Viral hepatitis. Sagittal image of the liver, left image, demonstrates increased echogenicity of the portal triads appearing as numerous echogenic dots, arrows, that produce a starry sky appearance. Sagittal view of the gallbladder in the same patient, right image, shows marked diffuse gallbladder wall thickening, calipers, which is commonly seen in acute hepatitis. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Viral hepatitis is infection of the liver by a hepatotropic virus. Hepatitis B and C cause chronic disease. The most common imaging finding is of a normal liver. When imaging is abnormal, the most common findings are periportal edema, starry sky pattern of increased portal triad echogenicity on ultrasound, fluid on both sides of the portal vein on CT and MRI, and gallbladder wall thickening, edema. Pyogenic abscess. Grayscale ultrasound. Unenhanced CT. T2 weighted MRI. Ultrasound, left image, shows a heterogeneously hypoechoic lesion corresponding to a hypodense lesion with foci of gas on noncontrast CT, middle image. This lesion was heterogeneously T2 hyperintense on MRI, right image, with enhancement and restricted diffusion, not shown. Hepatic abscess is most commonly caused by a bowel process and resultant infectious nidus carried through the portal system to the liver. Common causes include diverticulitis, appendicitis, Crohn's disease, and bowel surgery. E. coli is the most common causative organism. Imaging features of hepatic abscess may mimic metastasis, appearing as a ring-enhancing mass on CT and MRI. Reactive perilesional hyperenhancement may be present. On MRI, there is typically also central T2 hyperintensity and restricted diffusion. Pyogenic abscess continued. On ultrasound, Infection starts as an ill-defined area of altered echogenicity, phlegmon stage, which evolves into a well-defined hypoechoic structure with internal echoes, mature abscess. Cholangiotic abscess can be seen with bacterial cholangitis, or may occur in patients with biliary stents, prior sphincterotomies or hepaticojejunostomies due to gastrointestinal reflux into the biliary tree. Tuberculosis Tb. Tuberculosis Tb causes granulomatous hepatitis, usually secondary to hematogenous spread from primary pulmonary TB. Lesions may be micro or macronodular, rare, with multiple small hypoechoic hypoenhancing nodules or larger mass-like areas which demonstrate variable enhancement. These findings are often accompanied by hepatosplenomegaly. Fungal infection. Hepatic fungal infections typically show punctate, hypoenhancing microabscesses on CT and MRI and tiny hypoechoic lesions on ultrasound. Lesions are T2 hyperintense and restrict diffusion on MRI. Prior asymptomatic exposure and/or treated disease may show punctate, echogenic calcifications, granulomas. Histoplasmosis. Histoplasmosis is another form of granulomatous hepatitis secondary to the endemic fungus Histoplasma capsulatum, which is most commonly found in the Ohio and Mississippi River valleys. It is more common in immunocompromised patients but can be seen in immunocompetent patients as well. Hepatic involvement is usually secondary to spread from pulmonary histoplasmosis. In addition to the typical imaging findings of fungal infections, hepatosplenomegaly and hypoattenuating lymph nodes may also be seen. Pneumocystis jirovecii. Hepatic pneumocystis jirovecii is seen in disseminated disease in the severely immunocompromised. Hepatic infection is classically secondary to the use of inhaled pentamidine to treat pulmonary pneumocystis pneumonia, as pentamidine is not absorbed systemically and thus would not prevent hepatic infection. Candidiasis. Systemic Candida infection is almost always seen in immunocompromised patients and may seed the liver, and commonly the spleen as well. Non-contrast CT shows innumerable tiny hypoattenuating lesions scattered throughout the liver and spleen, arrows representing candidal microabscesses in a bone marrow transplant patient with fungemia. Echinococcal disease. Hepatic echinococcosis is caused by ingestion of the eggs of Echinococcus granulosus, which is endemic in the Mediterranean basin and associated with sheep raising. Echinococcal eggs can develop into hydatid cysts. Hepatic echinococcus. Ultrasound left image shows a complex, primarily hypoechoic mass in the superior aspect of the liver containing a hyperechoic undulating membrane, red arrow. Contrast-enhanced CT right image shows a fluid attenuating cystic mass, yellow arrows, containing an undulating membrane, red arrow. Case courtesy Cheryl Sato, MD, Brigham and Women's Hospital. On CT and MRI, a hydatid cyst is a well-defined hypoenhancing cystic mass featuring a characteristic floating membrane or an associated daughter cyst. Peripheral calcification may be seen on CORT. Classic ultrasound appearance is a large liver cyst with numerous peripheral daughter cysts. A highly suggestive finding is the change in position of daughter cysts as the patient is repositioned. The water lily sign is an undulating membrane within the hydatid cyst. Hydatid sand is a fine sediment caused by separation of the membranes from the endocyst. There is a theoretical risk of anaphylaxis with peritoneal spillage of cyst fluid, although these are often biopsied and drained uneventfully. Medical treatment is albendazole or mebendazole. Amoebic abscess. Amoebic abscess is caused by Entamoeba histolytica. A near-universal presenting symptom is pain, seen in 99% of patients. The most common location is near the dome of the right lobe. On imaging, an amoebic abscess is indistinguishable from a pyogenic abscess. Antimicrobial therapy is usually sufficient treatment, and drainage is rarely necessary. Cystic liver disease. Imaging simple cysts. On all imaging modalities, simple hepatic cysts are characterized by a round or oval, well-circumscribed, thin, nearly imperceptible wall. A few thin septa may be seen. On ultrasound, a simple cyst is anechoic, shows posterior acoustic enhancement, and demonstrates no internal vascularity on Doppler. CT shows homogeneous low attenuation, 0 to 20 Hu, and no contrast enhancement. MRI shows low T1, high T2 signal intensity and no contrast enhancement. Biliary hamartomas, von Meinberg complexes. Biliary hamartomas are small, benign cystic lesions which do not communicate with the biliary tree and are caused by embryologic failure of normal bile duct formation. Biliary hamartomas tend to be smaller and more irregularly shaped than simple cysts. Small biliary hamartomas may actually appear echogenic on ultrasound. Autosomal dominant polycystic liver disease (ADPLD). 40% of patients with autosomal dominant polycystic kidney disease (ADPKD) have a similar disease process in the liver, called ADPLD. Even in severe disease, hepatic failure is rare. On imaging, there are innumerable non-enhancing simple cysts throughout the liver. Von Hippel-Lindau (VHL). Von Hippel-Lindau (VHL) syndrome results from mutation in the VHL gene and is characterized by benign and malignant tumors in many organs. Within the liver, there are often innumerable simple cysts. Common imaging patterns of liver lesions. Multicystic, multiple simple cyst or biliary hamartomas. Caroli disease, saccular dilation of the intrahepatic bile ducts. ADPLD associated with ADPKD. VHL, cystic with internal echoes on ultrasound. Simple cyst with internal hemorrhage or superimposed infection. Abscess, hematoma, necrotic or cystic metastasis. Hyperenhancing lesions. FNH, adenoma, HCC, hemangioma, especially flash-filling subtype, hypervascular metastasis, fat-containing, focal fat, adenoma, HCC, angiomyolipoma, lipoma, pseudolipoma of the Glisson's capsule, rare, hemorrhagic, adenoma, HCC, metastasis, central scar, FNH, fibrolamellar HCC, giant hemangioma, calcified, mucinous metastasis, osteosarcoma metastasis, biliary cystadenoma, cystadenocarcinoma, hepatic capsular retraction, mass-forming cholangiocarcinoma, fibrolamellar HCC, epithelioid hemangioendothelioma, pseudocirrhosis, treated metastasis, confluent hepatic fibrosis, wedge-shaped fibrosis that may be seen in cirrhosis. Liver trauma. Overview of liver trauma. The liver is the second most commonly injured solid organ due to blunt trauma, second to the spleen. The 2018 Revised Organ Injury Scale (OIS) for liver published by the American Association for the Surgery of Trauma (AAST) includes imaging, operative, and pathologic criteria for grading injury. The final AAST grade assigned is based on the highest of the three criteria. The imaging criteria is based on CT findings and is more commonly used by radiologists. It is similar to the Organ Injury Scale for splenic trauma. American Association for the Surgery of Trauma Liver Injury Scale Imaging Criteria. Grade 1. Subcapsular hematoma less than 10% liver surface. Superficial laceration less than 1 cm deep. Grade 2. Subcapsular hematoma 10 to 50% liver surface. Intraparenchymal hematoma less than 10 cm in size. Laceration 1 to 3 cm deep. Grade 3. Subcapsular hematoma greater than 50% liver surface. Ruptured subcapsular intraparenchymal hematoma. Laceration greater than 3 cm deep. Any intraparenchymal vascular injury, i.e., pseudoaneurysm or AV fistula, or contained active bleeding. Grade 4. Laceration involving 25–75% of one hepatic lobe. Extraparenchymal extension of active bleeding into the peritoneum. Grade 5. Laceration or destruction greater than 75% of one hepatic lobe. Injury to retrohepatic IVC or central hepatic veins. When multiple injuries are present, advance one grade up to a grade 3. AAST grading system is limited for assessment of biliary injury. If injury to the biliary system is suspected, nuclear medicine HETA scan is often needed to demonstrate an active bile leak. MRI with hepatobiliary agents such as Eovist may also be helpful. Left image. CT angiogram axial image demonstrates a large subcapsular hematoma, yellow arrows, along the right hepatic lobe with no evidence of active extravasation. Right image. Portal venous phase CT axial image shows hypodense geographic, linear regions, yellow arrow, in the right hepatic lobe, indicating hepatic lacerations. Note the large right chest wall hematoma, red arrow. AASTLI versus ERINJURYSCALE. Liver transplant. Surgical candidates. The Milan criteria is used to assess appropriateness of liver transplantation in those with HCC or cirrhosis. To be considered for orthotopic liver transplantation, one must have single tumor less than 5 cm or up to 3 tumors, each with diameter less than 3 cm. No extrahepatic involvement. No major vascular involvement. Post-operative appearance. Normal findings may include periportal edema, minimal ascites, right-sided pleural effusion, and a small parahepatic hematoma. Complications. Vascular. Hepatic artery thrombosis is the most common vascular complication. Others include hepatic artery stenosis and pseudoaneurysm, IVC or hepatic vein stenosis or thrombosis, and portal vein stenosis or thrombosis. Biliary. Ductal stricture is the most common biliary complication. Leaks and obstruction due to cholecystolithiasis are also possible. Other complications include hematoma, abscess, hepatitis, splenic infarct, recurrent malignancy or primary sclerosing cholangitis, depending on the indication for transplant, and post-transplant lymphoproliferative disorder, PTLD. PTLD is a type of lymphoma caused by Epstein-Barr virus which can arise after solid organ or bone marrow transplant. Patients with renal transplants are at particular risk. PTLD may occur anywhere, regardless of which organ was transplanted. Treatment is reduction, withdrawal of immunosuppression. PTLD appears as a mass with a variable and nonspecific appearance. Vascular liver disease. Budd-Chiari. Budd-Chiari is hepatic venous outflow obstruction, which can be thrombotic or non-thrombotic. Thrombotic Budd-Chiari may be due to hypercoagulative states including hematological disorders, pregnancy, oral contraceptive use, malignancy, infection, and trauma. It is very rare to have primary Budd-Chiari due to congenital hepatic vein anomaly, as pictured below. Congenital Budd-Chiari. Axial contrast-enhanced CT shows massive enlargement of the caudate lobe, yellow arrows, and the right posterior segment. There is atrophy of the left lobe and right anterior segments of the liver. Collateral venous drainage in the periphery of the liver is seen as geographic peripheral hyperenhancement, red arrows. The causative congenital hepatic vein anomaly is not visualized at this level. Case courtesy Cheryl Sado, MD, Brigham and Women's Hospital. Acute Budd-Chiari presents with the clinical triad of hepatomegaly, ascites, and abdominal pain. Vascular findings include lack of Doppler flow or contrast within hepatic veins, thrombus in the hepatic veins IVC, and the formation of collateral vessels which appear as a spider web on venography. Budd-Chiari continued. Acute intraparenchymal findings include an edematous, mottled liver, nutmeg liver, with sparing of the caudate lobe. As discussed above, the caudate is often spared as it drains directly into the IVC. Flip-flop enhancement may be seen, with early central enhancement and delayed peripheral enhancement. Chronic findings are marked by progressive liver failure, with caudate lobe hypertrophy and atrophy of peripheral liver with prominent regenerative nodules. Veno-occlusive disease. Veno-occlusive disease (VOD) is destruction of small hepatic vessels secondary to toxin exposure, with patent hepatic veins. VOD is often seen in patients after stem cell transplant and exposure to certain chemotherapy agents. Imaging findings are nonspecific. In the acute phase, periportal edema, narrowing of the hepatic veins, hepatomegaly, heterogeneous hepatic enhancement, gallbladder wall edema and ascites have been reported. Liver Doppler may show decreased velocity or reversal of flow in the portal veins. In contrast to Budd-Chiari, the caudate lobe is not spared. The findings in chronic disease are similar to those of cirrhosis. Differential diagnosis in patients after stem cell transplant includes graft versus host disease (GVHD). Veno-occlusive disease is more likely if the right hepatic vein diameter is less than 0.45 cm, while GVHD is more likely if there is associated small bowel wall thickening. Peliosis hepatis. Peliosis hepatis is a rare benign disorder of sinusoidal dilatation and formation of blood-filled lacunae. It is often idiopathic but may occur due to certain medications, including steroids, oral contraceptives, tamoxifen and methotrexate, immune disorders, including HIV, immunosuppression post-transplant, and infections, including HIV, TB, Bartonella. CT and MRI show early central enhancement with delayed centrifugal enhancement. Ultrasound may show a non-specific hyperechoic mass. Cardiac hepatopathy. Cardiac hepatopathy is passive hepatic congestion from cardiac surgery, heart failure, constrictive pericarditis, or right-sided valvular disease, which may ultimately lead to cirrhosis. Imaging findings include enlarged hepatic veins in IVC, with reflux of intravenous contrast from the right atrium into the IVC and hepatic veins. The liver is typically enlarged and demonstrates mottled enhancement, nutmeg liver. Ascites is usually present. Hepatic Doppler. Normal anatomy and Doppler waveforms. MPV. CHA. RPV. Ra LPV. Normal equals hepatopetal number 1F out towards the liver. Hepatic arteries and portal veins. Number 1F, OW in the same direction. Ra equals right hepatic artery. LHA equals left hepatic artery. CHA equals common hepatic artery. RPV equals right portal vein. LPV equals left portal vein. MPV equals main portal vein. The normal hepatic artery waveform is pulsatile and towards the liver, called hepatopedal flow. Pedal equals toward. Normal hepatic artery waveform. Doppler tracing shows a pulsatile waveform above the baseline, indicating hepatopedal flow. The peak height corresponds to the peak systolic velocity while the trough corresponds to end diastolic velocity. A typical resistive index, Re, is 0.55 minus 0.7. Re is calculated by peak systolic velocity, end diastolic velocity, peak systolic velocity. The normal portal vein waveform is above the baseline, hepatopedal, and gently undulating, phasic, with velocity ranging from 16 to 40 cm/sec. The hepatic veins feed into the IVC and the right side of the heart. The spectral Doppler waveform is pulsatile and representative of changes during the cardiac cycle, though with the majority of blood flowing antegrade, away from the liver and towards the heart. The normal hepatic venous waveform has four distinct components, the A, S, V and D waves. Normal portal vein waveform. Normal hepatic vein waveform. Normal hepatic vein waveform. Anterograde. Into heart. Away from transducer. Retrograde. Towards transducer. S wave. Ventricular systole. A wave. Atrial systole. D wave. Ventricular diastole. V wave. Tricuspid valve. Opens. A wave. Atrial contraction, during which blood is forced retrograde, away from the heart, into the liver. S wave. Ventricular systole, during which a large volume of blood returns to the right atrium. V wave. Atrial overfilling, followed by tricuspid valve opening, peak of the V wave, and early ventricular diastolic filling of the right ventricle. D wave. Continued filling of the right ventricle during ventricular diastole, during which a smaller volume of blood returns to the right atrium. Portal vein pathologies. Portal venous pulsatility. While the normal portal venous waveform may be gently undulating, described as phasic, a pulsatile portal venous waveform is abnormal. The differential diagnosis for a pulsatile portal venous waveform includes tricuspid regurgitation and right-sided heart failure. Portal vein thrombosis. Thrombosis of the portal vein can be bland, simple thrombosis, or may be due to tumor invasion. Bland portal vein thrombus can be caused by a hypercoagulable state or may be due to local inflammation from pancreatitis or hepatitis. In infants, omphalitis or dehydration may also lead to portal vein thrombosis. Tumor thrombus is most commonly caused by HCC and is referred to as tumor in vein. Grayscale transverse image of the porta hepatis shows echogenic debris within the main portal vein, arrows. Color Doppler confirms partial portal vein thrombosis with lack of flow in the proximal portal vein, arrow. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Portal vein thrombosis, continued. Ultrasound of portal vein thrombosis shows lack of portal venous flow, often with echogenic thrombus within the portal vein. Expansion, enlargement of the portal vein can be seen with either bland or tumor thrombus. On color Doppler, flow within the thrombus suggests tumor thrombus. One potential pitfall to be aware of is slow, less than 16 cm/sec, or stagnant portal venous flow in the presence of portal hypertension, which may mimic portal vein thrombosis. Long-standing portal vein thrombosis leads to cavernous transformation of the portal vein, characterized by formation of multiple small paraportal collateral vessels. Cavernous transformation of the portal vein. Grayscale transverse image of the porta hepatis shows numerous tubular hypoechoic structures in the expected location of the portal vein, arrows. Color Doppler, right image, demonstrates flow within these collateral vessels, with no identifiable portal vein. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Portal venous gas. Portal venous gas is due to bowel ischemia, infarction until proven otherwise. If the cause of the portal venous gas is unknown, CT should be performed emergently. Grayscale ultrasound shows peripheral branching echogenic foci that may be transient or seen to change position on cine clips. Spectral Doppler of the portal vein features numerous characteristic spikes. In contrast to portal venous gas, pneumobilia tends to be more central, discussed later in the chapter. Portal venous gas. Grayscale ultrasound through the liver shows numerous tiny echogenic foci, arrows, in a branching pattern throughout the liver, extending to the periphery. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Portal hypertension. Portal hypertension is increased pressure of the portal venous system. Etiology is classified in relation to the hepatic capillary bed as pre-sinusoidal, sinusoidal, or post-sinusoidal. Pre-sinusoidal. Insult is proximal to the hepatic parenchyma, such as portal vein thrombosis. Sinusoidal. Insult is hepatic in origin, such as cirrhosis. Post-sinusoidal. Insult is beyond the liver, such as Budd-Chiari hepatic vein thrombosis or IVC thrombosis. Portal pressure is defined as a direct portal venous pressure of greater than 5 mm Hg, although the portal venous pressure is not measured directly. Ultimately, when portal venous pressure is higher than forward pressure, the portal venous flow may decrease below 16 cm sec or reverse, called hepatofugal. Fugal equals away, same Latin root as fugitive, which is diagnostic for portal hypertension. MPV, CHA, RPV, RA LPV. Reversed equals hepatofugal number 1F AU. Hepatic arteries and portal veins number 1F AU in opposite directions. In addition to slow flow or flow reversal, there are several secondary findings of portal hypertension. Dilated portal vein 13 mm is the maximal normal diameter in quiet respiration. Splenomegaly. Gamna-Gandhi bodies. Varices. Portosystemic shunts, most commonly gastroesophageal, paraumbilical, or splenorenal. Note that an isolated portosystemic shunt may not be caused by portal hypertension. For instance, isolated obstruction of the splenic vein from pancreatitis-related thrombosis or neoplasm may lead to a shunt. However, a recanalized paraumbilical vein is diagnostic of portal hypertension. Splenomegaly and splenic varices. Sagittal ultrasound in the left upper quadrant shows an enlarged spleen, calipers measuring 15 cm in craniocaudal dimension. There are numerous tubular hypoechoic structures, arrows, at the splenic hilum representing varices. Transverse Doppler ultrasound of the left lobe of the liver shows a recanalized umbilical vein, which is considered diagnostic of portal hypertension. Transjugular intrahepatic portosystemic shunt, TIPS. Portal hypertension and reversal of portal flow can be treated with a transjugular intrahepatic portosystemic shunt, TIPS, which connects a branch of the portal vein to a systemic hepatic vein. Ultrasound is used for surveillance of TIPS patency, starting with a post-procedure baseline. Routine follow-up is performed according to the following schedule: in 1 month, every 3 months for the first year, and then every 6 to 12 months. Flow in a patent TIPS will be towards the hepatic veins, and flow in the portal veins will be towards the TIPS. Therefore, flow in the main portal vein will be hepatopedal and flow in the right and left portal veins will be hepatofugal, highlighted below with yellow circles. MPV, RPV, RA LPV, TIPSLHA. Patent TIPS. Blood number 1F owes through TIPS to hepatic veins. RPV and LPV have reversed number 1F AU toward TIPS. MPV has hepatopedal number 1F AU toward TIPS. Patent TIPS. Color Doppler of the porta hepatis including the proximal TIPS shows flow within the TIPS, yellow arrow. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. U.S. can evaluate for stenosis of the TIPS. TIPS stenosis. Spectral Doppler of a TIPS shows a velocity of 45 cm sec, indicative of stenosis due to slow flow. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. High intra-TIPS velocity greater than 190 cm sec or low intra-TIPS velocity of less than 90 cm sec suggests stenosis. Intra-TIPS velocity change of plus or minus greater than 50 cm sec since the baseline study is also concerning for stenosis. Low main portal vein velocity, less than 30 cm sec, suggests TIPS stenosis. Transjugular intrahepatic portosystemic shunt, TIPS, continued. If the TIPS becomes occluded, the right and left portal vein will reverse and become hepatopedal. MPV, RPV, RA LPV, TIPSLHA. Occluded TIPS. No blood number 1F AU through TIPS. RPV and LPV have reversed. Now have hepatopedal number 1F AU away from TIPS. MPV has hepatopedal number 1F AU towards occluded TIPS. TIPS occlusion. Color Doppler of the porta hepatis including the proximal TIPS shows complete absence of flow within the TIPS, arrows. Case courtesy Julie Rittner, MD, Brigham and Women's Hospital, Boston. Hepatic vein pathologies. Increased hepatic vein pulsatility. Increased hepatic vein pulsatility is caused by right-sided cardiac abnormality, either right-sided heart failure or tricuspid regurgitation. Both conditions are characterized by accentuated on-V waves due to increased retrograde flow during atrial systole. Short. S wave. Accentuated. A wave and V wave. D wave. Right-sided CHF.